Last day of MBBS course is over. Now the student is faced with a quartet of 4 examinations as of today. Final MBBS theory examination, also known as 4th professional final examination. Final MBBS practical examination, 4th professional practical examination. Next one, I would like to call it as postgraduate medical entrance examination. Now it is known as next one, national exit exam 1, national entrance exam 1, whatever it is. And lastly, next two, a proposed licentiate examination, only after passing which the MBBS degree would be awarded. So these are the 4 exams that the student has to pass. Now, as of today, there are a few frictional areas, especially with respect to the postgraduate medical entrance examination, which of course is known as next one. Next to 2 also, there are some questions. Of all these 4, the next examination, or the All India Postgraduate Medical Entrance Examination, next one, is the one that is mired in a lot of controversies. It is yet to be held. The policy makers have come up with an idea of creating a multi-role examination, which is largely MCQ based, or rather I must say wholly MCQ based. 540 questions, if I am not mistaken. I may be wrong, I stand to be corrected, but as far as I know, 540 questions spread over 3 days, every day 3 hours, continuously for 3 days without a break, all subjects, beginning from 60% clinical, 20% preclinical, basic sciences. And this examination, this one examination known as next one, MCQ based examination, has been proposed as an examination that would replace the final MBBS theory examination. And this one next examination itself will serve a dual role or a multiple role. It would serve as the final MBBS examination, exit examination. It would also serve as the postgraduate medical entrance examination, where the marks obtained by the student in the next one would serve as the yardstick for deciding what course he or she would be eligible for and would be allotted for in the post-entrance examination during counseling. 3, it would also help as a checkpoint, as a toll gate entrance, wherein it would be decided whether the student is fit to enter house surgency or not, that is internship or not. This is about next one. And last but not the least, next two. Next two is 100% a brilliant idea on the part of the policymakers, Government of India. Next two is a licentiate examination. When it would be conducted, what it would be conducted, how it would be conducted, what is its configuration, we are not quite very clear. Every day there are news that comes and goes. We are not here to discuss all those things. Most controversial of them, next one. What are the key areas of concern from the student side? What are the key areas of concern from the policymaker side? It is there on your screens. I request the viewers to kindly have a look at it. The students are concerned that this is going to replace the final MBBS theory examination completely. At the same time, this MCQ examination is going to be proposed to be held immediately after the final MBBS theory examination, plus or minus with a very small gap. After a grueling examination of final MBBS theory, which spreads over 10 to 12 days very easily, or even more, without even 4 to 5 days gap, or maybe hardly with a 1 week gap, not even allowing the student to give time for preparation, the policymakers have proposed that this should be held back to back. This is the another area of concern. Third area of concern, the scores obtained in next one, that is MCQ examination, that would be the postgraduate medical entrance examination marks. So this is the biggest concern. And last but not the least, there was a proposal. If I am not mistaken, it is scrapped. And what is that? These scores are valid for a period of 3 years. Lock-in period 3 years. That means the student can access these for 3 years. I think that is scrapped if I am not mistaken. What are the concerns of the policymakers? It is there on your screen. The policymakers feel that it is important for them to upgrade the examination to a MCQ entrance examination type, because there is a lack of standardization of MBBS scores, because there is a lack of uniformity, because conducting next one immediately after final MBBS and prior to internship would help the student in evaluating himself or herself. Lack of interest during 1 year internship by the post MBBS graduate, resulting in not learning of clinical skills which are important for future medical practice. Knowledge, equivalence, transparency, skill and psychomotor domain. The main thing here, with due respect to the policymakers, is that they are trying to create an examination which they want to replace the final MBBS theory examination, based on the accusation that the final theory MBBS examination at present what is being held is mainly a from the memory type of examination, which is not evaluating the students perfectly, thoroughly, especially with respect to clinical skills. And they want to create a particular configuration of examination which is totally of the MCQ type, in which they want to inject and imbibe clinical analysis, thought-provoking questions, and they want to make sure that this is also serves as an All India postgraduate medical entrance examination. Why do we hold examinations? It is meant to examine the depth of knowledge of a student. How do you do it? You do it with a very thorough testing. You need a huge platform. If anybody in the nation thinks that by asking 540 multiple choice questions, A, B, C, D, E, no matter how thought-provoking, clinical-provoking, analysis, logic-based, no matter what they think, I'm very sorry to say, multiple choice question examinations are not the perfect, nowhere near the perfect yardstick or the metric to evaluate the knowledge, the complete knowledge that the student has gained over the past 4.5 years of MBBS course. You cannot evaluate this by a bunch of MCQs, no matter how well you have configured the MCQs. MCQ questions are not a substitute to the classical time-honored theory paper. That's it. MBBS is an ocean. If you want to know whether a student has learnt everything about thyroid, do you think that the entire knowledge about thyroid can be encompassed in one MCQ question? No matter how clinical, thought-provoking, do you think that just by framing a question, a 28-year-old patient comes with a swelling in front of the neck, which moves well with deglutition, the swelling from the past 2.5 years. The patient has not noticed any change in the voice or any other abnormality. The following are the investigations that are given in front of you. Which do you think is the most appropriate of all? Do you think that this question will test the entire knowledge about thyroid? It's an ocean. You cannot do it. Whereas when you have a classical long question, short question, whatever it is, medium type question, whatever it is, a theory-based question, that is where, that is how, that is when you have a chance to extract the complete knowledge, and you can know whether the student has learned everything about that particular organ system. And what is that question? Discuss in brief the clinical and surgical anatomy of the thyroid with special reference to the blood vessels and nerves. Write a brief note on the hormone physiology of thyroid and answer the following question. A patient comes with a swelling in front of the neck. The photograph is attached. Discuss in brief pathology of malignant tumors of the thyroid, their clinical symptoms, physical features, laboratory investigations, histopathological features of follicular carcinoma thyroid with a diagram, and outline medical, surgical and nuclear medicine therapy of the same. This being the question, when you frame such a question and allocate 20 or 25 marks, right from anatomy down to surgery, the student cannot escape. The student has to have had read, the student must and should have known, and the student must answer. If he or she doesn't answer, it would be very easy to know whether the student has a lacunae in his knowledge bank. The final MBBS theory examination, or the fourth professional theory examination, is the most valuable, most solid, most valid platform for evaluating the knowledge of the MBBS exam, of the outgoing MBBS student or the exam going student. MCQ questions can be a part of the paper. 90%, 90 marks, let us say, example 100 marks. 90 marks you can have theory, 10 marks MCQs. That is acceptable. But totally replacing it, it's unacceptable. Final MBBS practical examination. The fourth professional practical examination, as of today, is a very big event. We all know that. That is, the final MBBS student, after finishing theory examination, after 1 week or so, 1 week, 10 days, whatever the case may be, they will face the practical examination. The practical examination consists typically of 1 long case and 3 short cases. Afternoon session, it will be practicals, that is histology, slides, bones, osteology, instruments, x-rays, CT scan, pathological specimens, so many, and general viva, general questions. It's a very long process. What MERC would like to propose is a downgrading or a downsizing of the final MBBS fourth professional practical examination, surprisingly. That means to say that instead of 3 external examiners, 1 internal examiner, that is one of the professors, head of department or whatever it is, additional professor, associate professor, all the students, just 1 external examiner, 1 professor, head of department. And how many cases? 1 long case, 1 short case, and a bit of theory in the afternoon. That's enough. Why? You see, at the end of MBBS, what is it that is being evaluated? Mainly what is being evaluated is knowledge, theoretical knowledge and its application. It is not necessary to know whether the final MBBS student post MBBS has become a consultant or not. That is not the time when he or she becomes a consultant. No. The aim is to know whether the student has gained exposure or not. After exposure comes experience. When does experience come? Internship. Therefore, before internship, that is at the end of final year, what is needed to know is whether the student has seen cases or not, whether the student has seen all the cases there. the usual, the standard cases that are seen in day-to-day practice. More importantly, whether the student from the past 4.5 years has made a sincere effort to integrate all the knowledge, preclinical, clinical and paraclinical, all the three, has he or she developed the ability to integrate all these together in a holistic manner and apply it to the patient and come out with a particular plan for treatment. That is what is the aim of a final MBBS practical examination. I don't mean to dilute the standards. No, that is not what is being proposed. But what is certainly being proposed is a downsizing of it, because it is not necessary. Also, an argument would be made, and that is, no, already they have had a clinical exposure, etc. No. The most important point that viewers and policymakers especially have to understand is that a thorough practical examination, a full-blooded practical examination should be made only after the student or the individual has had a massive clinical exposure. Immediately they'll say for 4.5 years he's had a clinical exposure. No. That is not the real exposure. What is the exposure that we'll have? After 4 o'clock, they go to the hospital. 4 o'clock to 4:30, tea. 4:30 to 5, they spend time walking from the canteen to the hospital. 5 o'clock to 6 o'clock, maximum. That's it. 6 o'clock to 6:30, come back, play tennis, shuttle, etc. 7:30, relax, have bath. 8 o'clock, go to mess. 8:30, dinner, eat. 10 o'clock, loaf around, have tea outside, sleep. 1 hour. And in this 1 hour, do they have continuity? That is the key word. What is clinical exposure? What is clinical experience? Not exposure, experience. What is experience? Experience means a particular student must see a particular case right from beginning till the time the patient, God willing, is successfully discharged after treatment. That means to say, a patient has come with jaundice. Right from admission down to investigations in the ward, being followed, all the diagnosis, tests, investigation, results, treatment, what is the outcome of the treatment, whether it is a surgical treatment or medical treatment, etc., up till discharge. Does this happen? It never happens. It cannot happen. Why? Different students, 100 students are divided into batches of 10 or 15. They are posted in different so-called clinical postings, small clinical postings. Today they are in one posting, tomorrow they are in the OT, tomorrow they are in the OPD. They cannot follow. By the time they come to follow, the patient would have been taken to the theatre. They can't go into the theatre because they are not posted in the theatre. They are posted in the theatre, so they did not follow the investigations. Post all these things, at least have they followed in the ward whether there are complications or not. So no, they don't know. Why? Because they have a weekly test coming up, they have some seminar coming up. There is no continuity. No matter how extra effort, I'm not blaming the students, I'm neither blaming the system, I'm only speaking about reality, ground reality. Policymakers cannot dissociate themselves from ground reality. You have to be a part of the hospital in order to appreciate reality. And reality is that reality is that the students can have exposure but not experience. Immediately again there will be a counter. No, they are being posted on clinical postings right from the second year MBBS, they are having night postings. Again, same story. Post 4 o'clock tea, 5:30 to 7:30, they are there. The postgraduates, the MD, MS postgraduates, they are all busy case writing. There is also a house surgeon, there is also a lecturer, they are all busy working the cases. 10 students come, who are you? We are posted here. Okay, you go and have a look at the cases. They go, they just turn around some charts. Half of them may be looking at their mobile, giggling, chatting, web, WhatsApp. And then, sir, can we go for dinner? Mess will be closed. Okay, go for dinner. They are not bothered because they are not a part of this team. The team begins with the house surgeon and ends with the professor. These MBBS students are not a part of the team. They have just been posted for academic program, part of the exposure. Again and again, I'm repeating the word exposure. And then they come back 8:30, 9 o'clock, they come back. They just hang around. Just hang around. We see we have just admitted that patient with pain abdomen. You go and have a look. That is at 10 o'clock they start yawning, and 10:30 you can go and sleep in the duty room. We'll call you. Morning 4:35 they are off. This is the truth. So the final MBBS student comes with a exposure of clinical cases. This has to be examined. It is enough to examine with one long case, one short case, a short format of the practical examination. The aim of final MBBS practical examination, also known as fourth professional practical examination, must be only to filter out the very, very, very underperforming, below average final year MBBS student. So, MERC proposes final summary, downsize the final MBBS practical examination to a small affair. Make it a small affair. One long, one short, a small viva. One internal, one examiner, one external. That's it. That is to do with final fourth year practical. So, final theory is over. A vast platform, final theory. We will come in a detailed summary. We will explain, MERC will try to explain what is the configuration. But final MBBS theory, extremely important. Final MBBS practical, downgrade. Next one must be held only after the completion of internship of surgeoncy. No question of holding NEET back to back, holding next back to back after some 15 days or whatever it is of grueling theory examination, after another 1 week of practical examination without giving gap, within 2 to 3 days, announce an examination and force the students to attend a 3-day continuous MCQ examination, which will decide their future once and for all without giving them time to prepare. What do you gain by conducting examination without giving them time to prepare? Is there anything that is gained? What are you trying to test? Their knowledge or their ability to perform examinations back to back? What is achieved? What is being? Are they being trained to be some marine commando services or something wherein you don't sleep throughout the night and next day morning again you go for your routine? Again you fast without food and water and again go on a trek through 12 kilometers through the desert. This is not what they are not being trained for some para-special forces or something. They are there to answer an examination to the best of their ability. Give them time to prepare. What is the philosophy behind not giving them time to prepare? What is the philosophy? What is the logic? There is no logic. Absolutely not. Therefore, at this stage, before we come to the final configuration of the All India Postgraduate Medical Entrance Examination, it would suffice here to say that MERC proposes only one thing. Next All India Postgraduate Medical Entrance Examination must and should be held after the completion of house surgency. Last, we come to the next two licentiate examination. There are only two things that here MERC would like to raise a question. Most important, only one, and that is, this is a question that has been raised even in the internet. The next two licentiate examination will be conducted after house surgency. The question that is being raised by the people are, how will you conduct this examination? Do you mean to say that after 2 months of rotation in general surgery, there will be a next two licentiate in surgery, 2 months medicine, licentiate in medicine, 2 months OBG, licentiate in OBG? Will you go on having for every 2 months, 100 students will be facing examination? Is that how it is going to be done? What will be the pattern? What will be the configuration? How will marks be allocated? What is the type of examination? What is the pattern of examination? These are the questions that are going around. MERC proposes a very simple, very obvious answer to all these questions. And the solution is, after completion of house surgency, next to licentiate examination should be held. That examination will be nothing but the final MBBS fourth professional practical examination. That's it. That examination which was proposed to be downsized, shrunken by MERC, the same examination must be translocated to the post-internship scenario, where we have assumed or we feel that the student has completed his experience, his or her experience, exposure. He or she has stayed integrated with a particular team, medical team, surgical team, OBG team, orthopedics team, pediatrics team, emergency medicine, all those departments. Every student has gone through a 2 months rigorous training, exposure, experience, and that we want to know, we want to evaluate. The policymakers, the teachers, ultimately, they want to evaluate the students. How do you evaluate? By a practical examination. The same final MBBS practical. The time to conduct the final MBBS practical examination is the post-internship scenario, wherein a mega practical examination must be conducted with 1 long case, 3 short case, Viva OC, models, X-rays, instruments, bones. Along with that, most importantly, MERC would like to add another segment to this examination, the most important, and that is ward rounds. What are ward rounds? Ward rounds are actively, it is not passively. The student sits in front of the examiner and the student says, there is a patient with jaundice, he or she has come just now, how do you proceed with it? No. You take the students, you take them to the medical ICU, take them to surgical ICU, take them to the ward, take them to the emergency, take them to the casualty, wherever it may be. And there is a patient literally in front of you, patient on the ventilator. Ask them questions. Patient is on ventilator. You have worked in the ICU during your internship. You have followed patients on ventilator. Okay, now you tell me, is this patient on ventilator? How is he or she doing? Would you like to take off the ventilator, that is the tube from the ventilator, and allow the patient to breathe himself or herself? When do you take off the tube? When do you not take off the tube? When do you put the tube? When do you not put the tube? What are the criterion? What are not the criterion? How do you interpret blood oxygen, blood carbon dioxide levels? This is real examination. This will bring out the real practical metal, METTLE. That means the real practical experience, whether the student has really followed the patient on ventilator, emergency, medical, ICU. In summary, we have the 3 examinations that are there in front of your screen. So to summarize, the placard is in front of you. Final MBBS professional theory examination would provide a spacious platform for evaluation of total knowledge. Raise the minimum pass percentage to 60 or 70% from the present 50%. Exhaustive theory paper. Questions pertaining from every organ system, every topic. Upgradation of the theory by introducing clinical problem solving approach based theory paper. Covers both preclinical and paraclinical. Standardized answer papers to be provided to the paper correctors all over India, pan-India, all India common central paper by a central paper sending committee, which will bring in uniformity of examination pattern. If some states declare that the synchrony of timing would not be possible, then too uniformity would be maintained by a central state joint paper setting committee. Standardized answer papers to be provided. Extra 30 minutes writing time should be given to the candidates who wish to write more specific and broader answers. This test is for the vastness and completeness of knowledge, not the speed or pace of writing. Final MBBS 4th professional practical examination to be a condensed version. 1 long case, 1 short case, Viva OC. Core purpose, filter out only the most underperforming students. 1 internal, 1 external. Next to post-internship licentiate examination. Exhaustive practical examination, which includes 1 long case, 3 short cases, ward rounds, Viva OC, instruments, models,